the first piece is that, when we think about Ontario Health Teams and the mandate for Ontario Health Teams around population health and integrated care, in population health and improving value really means both the health of the population and equity. And I've skipped the slide, but maybe you can imagine it. I'm sure it's going to be up in the next couple of events, where we think about population health, and what we need to do is both shift the curve and improve population health, and also squeeze the curve, which means that we are bringing the different ends together by bringing up those people at the lower ends of the strategy. And I think there's a new strategy in the NHS called 25, where they're focused on the 20% of the population, that bottom quintile, and improving care. And I think in the next few months, we'll bring some people in from the NHS to talk about some of the work that they are doing. So that really is both the need to improve the overall health and equity. And here's our quadruple aim, framework as we talked about it. And we talk here about how are we measuring these pieces. So we have surveys for patient experience and also for provider experience. And we're also collecting some patient-reported outcome measures in that survey, and using improvement indicators, mostly based on health admin data. And then also our improvement indicators look at cost containment. And equity, we said, should be measured and as appropriate to each quadrant. So let's talk a little bit about how we're doing this. One of the spaces is to say that patient experience measures are analyzed using individual social demographics and social determinants of health. And I'll show how that is. But because we are collecting data right from the own individuals, we can have that information. We can ask them things about themselves. And I think it can be quite enlightening when we do that. Much of our work at the HSPN is based on health administrative data. And we have both patient and system measures that are analyzed and reported primarily by neighborhood material deprivation. I'll describe that again in a little bit more detail. And we have both OHT level analyses where we show improvement indicators according to the degree of material deprivation in the OHT, but also to each OHT, we've been sending data back. And in that data, for all of our indicators, we let you know what the what this performance or the improvement ratings are for each quintile of material deprivation. And then provider experience measures, we also have that individual sociodemographics approach. So when we have the individual sociodemographics, coming back to that equal opportunity for individuals to attain their full potential health, these are some of the things that are both non-modifiable and modifiable. So some of the non-modifiable ones being age, sex, and race and ethnicity, and then ones that might be somewhat modifiable around food, housing, and income insecurity. I would say social isolation is hopefully modifiable. Rurality, and then according to what people's health needs are. So we want to make sure that people are getting equitable access to care depending across their health needs, particularly important in the health space. So here are some of those that are measured. So this is about just under 4,000 people that had responded to the HSPN OHT patient survey. We have this available for use in all OHTs. And here are the numbers. So when we looked at it, about 70% of people said they had no difficulty paying bills. Another, say 15% or so said that they rarely, but then we have these people that sometimes, and a few people always, are having difficulty paying their bills out of the Ontario Health Team population. And this isn't through any concerted effort to target people who might be in lower socioeconomic groups. This is just in a general population of OHT respondents who went on, clicked into our computers and answered the surveys. Were they worried about losing housing and enough money left for food? So those three pieces. And then over on the right side, we have social isolation. This is out of the Stanford measure of social isolation, where we talk about feeling isolated, feeling left out, and lacking companionship. They're similar and related, but they are a little bit independent. So these are some of the ways. We also have gender and sex and some of the and race and ethnicity, and we'll see some of those results a little bit later. Material deprivation. This is one of the indices that's available through the Ontario Marginalization Index. It's an area level measure based on census data. There are 4 components to the overall marginalization index: residential instability or housing insecurity, ethnic concentration, which is both recent immigrants and or visible minorities, the dependency, which is about the portion of the population that are not working versus the ones that are working. And then here is this space in the material deprivation, which we focus on and think it's probably the best of the indices in terms of its comprehensiveness and in different ways. So it includes aspects related to income, education, family structures, housing quality, as well as the ability to access and maintain basic needs. It has a close connection to poverty, and it has been linked to poor health outcomes. And you'll see this both in our work, and also we've done some comparative work with England using material deprivation. They actually fund organizations with an adjustment factor for their social deprivation index, which is very similar to this one. So here, some of the people have seen this exact one or previous iterations of this. We now have all 50 teams here. And here what we have is the proportion of the population in each of the Ontario Health teams finds itself with a population in each quintile of that material deprivation. So down at the bottom, we see one of the OHTs that has 50% of their population are in the least deprived or the highest SES group, and only about less than 10% of that OHT has its population in the most deprived quintile. But if we look up at the very top of the chart, there's an OHT where almost 40% of their population are living in the most deprived quintiles, most marginalized, and less than only about 10% of their population living in the least deprived areas. So quite a bit of variation across the Ontario Health teams, and this just deals with the population that you need to address and mitigate. So here, let's start looking into some of the data. I just want to give you a little bit of a flavor of what some of the population demographics are for Ontario Health teams. And now here are some of the areas from the patient survey. And this is we have the 6 attributes of patient-centered care that are up top. And then we have other measures, including health services, transitions, as well as these highlighted at the bottom, some of the measures that we're interested in as it relates to equity. So I'm going to look at not the entire survey, but just a couple. So here's on the left, difficulty paying bills at the month, and on the right, feeling isolated from others, just 2 of the dimensions that we might be considering in equity. And we're measuring here whether the time that they had to access a usual provider, how acceptable that was, like much too long, somewhat too long, or about right. And we see here some not major, but minor gradients according to whether people have difficulty paying their bills, and those who always have difficulty paying their bills seem to have the most difficulty in accessing a provider. I can't explain exactly why that is, but it's appears to be true with less than 5% of the people who never have difficulty paying bills, and more than 20% of the people who always have difficulty paying bills having that access challenges. Maybe it's an hours issue, maybe it's a time, maybe it's just a navigation issue, but it's clearly a bit of a gradient. And when we look at the feeling isolated from others, again, we see another gradient here. And this is just in terms of timely access, the first thing that people need to do. Once people have accessed care, what about their confidence that the healthcare provider will check up to ensure that their needs are being met? And what's the level of confidence that people have? You see that this varies a little bit across whether people can pay bills at the end of the month, a little bit of a gradient, not too strong, but it's there. But feeling isolated, especially when you get into that population that are always feeling isolated from others, they are having much more difficulty in having confidence that someone's actually checking up on them. And that's probably tightly related. If no one's checking up, they're feeling more isolated. So this is just a couple of the ways that we're looking at those patient experience measures out of the survey, and looking at them across these stratifications being the simplest way. And we're going to talk in the future webinars about more sophisticated ways, but just simple stratifications to get a sense. Also looking through the indicators, we thought maybe there's 2 here. You could put these in different buckets, but they might be proxy measures for patient experience. One is whether people are needing to access mental health. Is that in the emergency department first? And actually, the interesting thing here is that so this graphic here, we've shown these before, but I'll pause because people may not quite remember them. This is the total number of people in each of these bars where they access the emergency department for a mental health and addictions issue across the province of Ontario. stratified by which material deprivation quintile the individual comes from. The blue meant that they'd already had contact with the healthcare system, and the green means that this is their first contact. So we see here that actually the proportion in the green bars doesn't vary massively across the different material deprivation quintiles. What we do see here is that the people in the area of greatest deprivation access the emergency department a lot more than anybody else. But I would say this isn't a very strong gradient. So everything is not always strong. And here's another one actually that is not super strong. Deaths in hospital are not very strongly related to material deprivation either. In this graphic, we're showing the proportion of the population that die, proportion of deaths that happen in a hospital for each of the OHTs. And the OHTs are colored by the proportion of the population that are living in the most deprived areas. So the darkest blue are the OHTs in the top quintile with the most deprived patients. And you see they actually appear all the way across here from relatively low deaths on the far left side to high numbers of proportions of deaths in hospitals. You can find this on our end-of-life specialty report on our website. So what about patient outcomes? So here again, we're going to start with the patient-reported outcomes first, and then we're going to have these more population ones. So here, this is overall self-rated health, fair to poor, good or very good and excellent, according to difficulty in paying bills at the end of the month. You can see a very clear gradient here that as people have more difficulty paying bills, they are definitely less likely to be excellent or very good, more likely to be in poor health. And again here, this is around whether people felt isolated. That's now the stratifications across the bottom. And again, we see quite strong health relationships according to those people isolated. And then we have it for mental health, even stronger gradients when we're considering mental health outcomes for people. And I'm just using these two examples to let people just have a sense of how strong some of these relationships actually are. They're quite remarkable. And I know that this has changed my view on noting about social isolation as really being an important social determinant of health. And this is some of the first data we've actually been able to really pinpoint. Looking at the hardest outcome we have, which is premature mortality, this is this sort of one of the strongest measures. It is very strongly, the tau correlation here is 0.5, which is very strong relationship between premature mortality and the proportion of the population that are living in the most deprived areas. It's a very striking figure. And we also have shown to OHTs what the differences are within OHTs. I didn't put it up here, but very often within an OHT, and we've shared these results out with each OHT, it is more than twofold that the premature mortality rates in the most deprived neighborhoods are more than 2 times higher than they are in the least deprived neighborhoods. It is quite something. But even here, then we also have changes in activities of daily living long scores. These are functional measures for the frail older adults. This graph is shown in our older adults report. And here we actually don't see a very strong relationship. It's relatively weak, and it's actually inversely correlated with the people are having more declines when they are in the groups that have the less deprived neighborhoods. So again, needing to look at each one individually and consider what some of the drivers might be. We have a couple of measures here around cost. I'm working my way around the quintuple aim, the quadruple aim, sorry, and the correlation here with total cost is also relatively high. A strong correlation with deprivation. We see most of the OHTs that have higher costs also have more people living in the more deprived neighborhoods. And that's the challenge they have to face, is how do we manage that? Moving last step here in our walk around the quadruple aim is provider experience. And I'm going to show here just one of the areas, I think, across 2 dimensions, or 2 of the areas, 2 of the indicators. This is our provider experience survey. The data I'm showing here come from one of 4 OHTs that have launched this. And we have about 400 and something odd surveys now in the area of provider experience. More OHTs are adopting it. And we don't have all the data. I actually came across an OHT the other day that had adopted particular items out of this survey for use. And you're free to do that too. It's available on our website, but we can also provide some support internally with an online resource for you to complete the surveys amongst your staff if you want. But here we see, whether people had an opportunity to contribute to major strategic decisions according to age, race, and ethnicity. It's a bit of a combined category. And then also by gender. That's man, woman, and prefer not to respond, prefer not to answer. They're showing, and you can see that they are not linear relationships. These don't have clear, sometimes they're very categorical, and I haven't outlined these up in any ordering at this point in time, but to show some variation. And I'll say that the sample sizes in our race and ethnicity groups are still relatively small, given the respondent populations that have answered so far. I think we're about 80% white in the responses, but there's still substantial and enough in here to have people represented in pretty well each one of the response categories. And then this is a question around burnout. We hear a lot about burnout, and so we have this item around whether people how they best describe their situation at work. Enjoying their work is in the blue at the very top, and feeling completely burned out in the red at the bottom, and symptoms of burnout not going away being in the orange. So the kind of orange-red might be the areas we're most concerned about. And I'll say, when we look at age, it's the earlier age, 35 to 49, those are the people that are feeling the most burnt out. The younger and the older, and presumably the ones that are 65 and older, have a lot more autonomy. They also had better ability to make decisions in their work. So those individuals, the ones that are still working, seem to be having a better time of it. And then we also see going across by race and ethnicity and gender. So these can be, dependent upon what your OHT is. Really looking at it within that lens is going to be the piece. This is just provincial data across all the OHTs, but OHTs themselves that have conducted this being able to do that. So, I'm really interested. Not very good at talking and paying attention to the chat, but I'll come back to do a lot more chat. But some of the takeaways here is that first off, there's considerable variation across Ontario health teams in the distribution of the attributable population in the areas of low to high material deprivation. Every OHT is not facing the same population. The equity measures in the patient surveys are also showing some important issues related to the social determinants of health, and particularly also social isolation. The equity measures in the provider surveys are a little less striking, but smaller sample sizes means we still have relatively little information. And so I'd encourage us to continue to pursue this. And within OHTs, we are happy to support our provider survey through the online tool that we have made available through REDCap as well. So it is a secure environment. And we have from our website ways that you can go in and look at the provider patient surveys and think about how you can collect that information individually. Some of our kind of key takeaways here are that social determinants of health are substantial and they are statistically related to patient-reported experience and outcomes in that survey. So we need to be cognizant of this. And so today our starting point is measurement, and we're just saying that's what our measurement is telling us. Some of the measurement proxy measures that we have, like maybe ED first, they have less association. Some of them do, but not all of them. And then the measures of health outcomes, such as premature mortality, tend to have higher associations with area level deprivation, and that lines up also with the patient-reported outcome measures. Healthcare cost itself was moderately to strongly related to area level deprivation, meaning that if you have more deprived neighborhoods, it's costing more to care for those people. I think there's two things to think about there. One is continuing to meet those needs because they're higher needs patients. But the other thing is also what are the other determinants that aren't healthcare that are affecting those individuals and then their health-seeking behavior as they have greater needs. And that's, I think, where we really want to get the conversation to as we evolve over the next couple of webinars and, over the future of Ontario health teams. And finally, just our provider experience has some, but relatively in our sample so far, variable associations with individual sociodemographic measures across the different groups.